All right, so now we're going to get into antepartum care. So this is going to build right off of the previous PowerPoint on prenatal assessment. It's going to contain some more in-depth assessment as well as some more in-depth educational topics for pregnant women. So this will be probably a little bit longer than the previous one, but contains a lot of very important information for this unit. Some of the first topics we're going to educate pregnant women on is in regards to self-care. And there's several topics we'll touch on here. So first is breast care. So with breast care, there's a couple things that are really, really important. Primarily, good support and hygiene during the pregnancy to support the changes that are going on in the breast during that time. So good support can be challenging because with the enlargement in breast, it does require some financial considerations. Activity in an uncomplicated pregnancy should continue for the most part. It can continue for the most part. So women who, like the woman in the picture here, who have been lifting and who have been doing it safely and are trained to do that, they can safely lift pending any complications in pregnancy. However, pregnancy would not be a good time to start a new athletic program. Some exercises that would be beneficial for all women in pregnancy would be a pelvic tilt. So that's really just sitting back or laying down and tilting your pelvis forward. So you can kind of feel, if you do that, even just sitting in the chair or laying on the ground, you can kind of feel that it kind of moves your back a little bit. And this can be very beneficial in assisting with back pain during pregnancy. Abdominal exercises where women tighten their abdomen with each breath can be beneficial, as well as Kegels for the perineal area. With regards to sexual activity, again, in an uncomplicated pregnancy, there's no need to limit. There's some change possibly in desire and response related to both males and females, and this can impact sexual activity, but as long as there's no complications, there's no reason to stop sexual activity. Dental care, just being made sure to maintain good hygiene and vitamins. Same with bathing. One of the other cautions with bathing that you want to be consider is cognitive safety. You know, the center of gravity is shifted, some of those things. So being cautious and getting in and out of wet surfaces, and when you're walking on wet surfaces, would be very important to caution women on. Also, the potential for very warm baths or hot tubs. There is some additional vasodilation that occurs when we're in hot water. So hot tubs are generally contraindicated in pregnancy because we're already in a state of vasodilation with a lower blood pressure. And if we vasodilate further because of that heat, that can cause the woman to potentially pass out or have some other bigger concerns. So that's why that caution is to really avoid those during pregnancy. Employment, you really just need to think about occupational exposures. And then travel. Travel comes up frequently as a question for pregnant women and what's safe or what's not safe. So in general, you know, it's okay to travel throughout most of the pregnancy. Thinking of making frequent stops. There's some changes in pregnancy that increase the amount of fibrinogen that's going on within the body. And this leads to needing to make sure you're getting up and moving your legs and things like that. Staying hydrated, using the seatbelt. Even flying is okay for healthy pregnancies. Most airlines will allow women to fly for up to 36 weeks gestation. Making sure they're staying hydrated. Another consideration, especially on long flights, would be to wear some support hose to help with that circulation in the legs and prevent any complications related to that. The other discomforts, I want you to again refer back to that handout that you have and review that for discomforts that are going on in pregnancy and ways that we could help to encourage women to manage those. Now we'll get into some of the diagnostic testing and other bigger assessments that are done during pregnancy by nurses. All right, so fetal activity. This is an educational piece that we will talk to moms about, and we also then, when we ask about fetal activity on that antepartum record, this is really what we're talking about. Once they get to 28 weeks, we're not just talking about if they feel baby move, but is baby moving enough? So maternals, this is a maternal assessment, so the moms do this on their own. They should do it every day, and what we're looking for is counting to 10. Are there 10 kicks in 2 hours? And this should start at around 28 weeks. So the website listed there gives you some information, but they can keep a chart, keep track. Generally, we suggest that they do it at the same time every day. So often we hear women say, oh, baby's always so active when I'm trying to go to sleep, which may be true, or it could just be that we're less active at that point, so we notice the fetal activity a little bit more. And that's an okay time to count. It's a really good time. You're relaxed, you're sitting, and you can count and see what baby's doing. So ensuring that you're feeling some. If there's any decrease in fetal movement or absent fetal movement, that would be something to report to the provider pretty quickly. Ultrasound. So ultrasound, while this is not a nursing task, it isn't something that we would be talking to patients about why they're being done, what's going on, what they're going to be looking for. So why would a ultrasound be done? Why is different than what some of the other things we might gain from it. So ultrasounds can be done for a variety of reasons. Early on, it can be done just to confirm that a woman is pregnant and to look for the number of fetuses. It has the ability to confirm fetal heartbeat and breathing if we have any concerns about the pregnancy. Sometimes it's ordered to check fetal size and weight to see if growth is appropriate. Most women have a prenatal ultrasound done around 20 weeks of gestation, and the reason for that one is detection of anomalies. It's usually referred to as the fetal anatomical survey. So during the fetal anatomical survey, the fetus is at a point where we can really look at all of the major organs via ultrasound to see if everything is developing in a normal manner. Are there any congenital anomalies that we see that we need to maybe take into consideration for delivery? So that's a really, really important one. One of the things that happens often at that fetal anatomical survey is that many people will be able to find out the gender. Now, this isn't the reason why this ultrasound is being done, but it is a secondary possibility that goes along with looking at normal development. Amniotic fluid index, so that's another thing we can see by ultrasound. How much amniotic fluid is present? Is it a normal amount, or do we need to be concerned if it's too low or too high? And then looking at the placenta. So as the placenta ages, as the pregnancy progresses, the placenta will change a little bit in appearance, and we can kind of see that it's getting a little bit more aged. So as it ages, maybe in a post-term pregnancy, it maybe becomes a little less effective. So that's something really important. We can also see that the placenta is attached all the way around, that it hasn't started to come detached from the uterus prematurely. So lots of important things on why we might do an ultrasound and lots of information that could be gathered. So as a nurse, you'd be talking about those whys. What are we looking for when we're doing this, and talking to the patients about that. Ultrasounds would be done either transvaginally or transabdominal, although transabdominal is more common as the uterus is more of an abdominal organ. So now we're going to get into some of the diagnostic tests, and these can be a little bit challenging to wrap your brain around, but they're very important to understand how we monitor fetal well-being when in a little bit more specific ways. So a non-stress test could be done for a variety of reasons. A non-stress test is looking at fetal well-being by monitoring their heart rate. And on the picture where you see the strip, what you see there on the bottom part is actually looking at uterine activity, and then the top line where it's got the little red notches, that's looking at the fetal heartbeat. So uterine activity, if they were having contractions, you'd be seeing those on that bottom. We don't see any contractions here in this picture, but we do non-stress tests to check for fetal well-being if maybe mom has having some complications in the pregnancy, or maybe she hasn't been feeling baby move as much as normal. If there's anything where we're not sure how baby's doing and we want to just make sure that everything's good, this is a very easy, non-invasive procedure to do. So it uses the fetal monitor. We put the two belts on the mom, and we're really just looking for accelerations in the fetal heart rate. So if you see, you kind of have a baseline heart rate on that picture. So that's kind of where does the heart rate kind of hover around without movement, and we can kind of see that there. And then each of those red notches is where the mother noted that she felt fetal movement. And with each of those, we see that that heart rate went up, which is what we anticipate because of that parasympathetic nervous system and the pacemaker that the fetus has, and that they respond to activity. So when we are looking to see what makes it acceptable, what kind of acceleration do we need? Well, we're going to monitor for 20 minutes, and we want accelerations to be 15 by 15. So 15 beats above baseline, and it needs to last for 15 seconds. So several of those here are going to meet that requirement. The second one might be a little bit short, but again, most of the accelerations you see on this picture do go 15 beats above baseline and last for 15 seconds or more. So this would be a reactive non-stress test. So reactive for non-stress tests is good. Non-reactive non-stress is not good. Non-reactive means the baby's not reacting to activity, or they're not really being active at all. So that would not be a good sign. Some things that could impact this. If baby's in a sleep cycle, we might need to monitor longer. Babies do sleep on and off in utero, and so sometimes we'll need to kind of wake them up, and we can do that through noise or giving mom something to drink or eat, variety of things we could do, and we might monitor a little longer than 20 minutes to see if we get those reactions. Another note is if the woman is less than 32 weeks gestation, instead of 15 by 15, we look for 10 by 10, just due to fetal development and how they manage. They should still react to activity, but it may only be 10 beats above baseline for 10 seconds, and that would still count as reactive if there's 2 of those in 20 minutes. So this is a really common test that's done. It's utilized very effectively to monitor for fetal well-being. We're going to do some more practice in class on looking at these strips for reactive or non-reactive. All right, so now let's go to biophysical profile. So biophysical profile is a little more involved, and this test would be ordered by the provider if we're more concerned about baby. So non-stress tests can be used just for general monitoring if there's a high-risk pregnancy. But what if the non-stress test is non-reactive, or what if we're really concerned? So a biophysical profile combines that non-stress test with a few quick ultrasound considerations. So radiology would assist with this, as well as the nursing interpretation of the non-stress test, or NST, to come up with a score. So each of these areas can score up to 2. So we have 5 areas, and you would score up to 2. So the max score is 10, and it goes down, as you can see here, based on that. So if we have, even if the non-stress test is non-reactive, we could still have a score of 8 if all of the ultrasound components are okay. And as you can see, that's still an okay result on that biophysical profile. But if any of those other things are missing, then we start to become more concerned about baby. So this just gives us like, oh, we're really worried. This baby maybe needs to deliver sooner. And that's, the provider will be the one really making that judgment, but just knowing what is the biophysical profile, how is it done, and what's my role as the nurse. So as the nurse, you are doing the non-stress test component and educating the patient on what to expect. They're going to go and have an ultrasound to look at a few things with baby. And then relaying the information to the provider to then decide what the best course of action is. So this is a common test that's done because it's pretty easy, and all hospitals readily have ultrasound technology available. So it does really guide the provider very well. Lastly, and this one is not done as much now, because of the accessibility of the biophysical profile, we don't do contraction stress tests as often today in the hospital setting. But these were used to evaluate the function of the placenta. Same as the biophysical profile, because if the placenta is functioning, all of those things would be looking good in the biophysical profile. But what we see here with the contraction stress test is we're looking at the response of the fetal heart rate to uterine contractions. And these contractions could be spontaneous, meaning mom's having contractions on her own, or they could be induced via some medication that's given to induce them. So we can look at how the baby's going to handle those contractions. So in this, we can see there's a few different areas at the bottom. So what we want here is a negative, okay? So this is different than the non-stress test. The non-stress test, to have reactive, or what we kind of would think of as positive, we wanted to see accelerations. But the contraction stress test, we want negative because it's looking for decelerations. And we don't want to see decelerations in the fetal heartbeat. So the negative here at the top doesn't show any accelerations, but there's no decelerations of the fetal heart rate, so that looks pretty good. We're going to continue to monitor. But at the bottom there, opposite of that, we see a positive contraction stress test. So here we see that at the peak of each uterine contraction, that fetal heart rate is starting to go down. And that results in a late deceleration, and it would be a positive contraction stress test. So this occurs for a couple of reasons, but primarily we're looking at that placenta should have enough reserve in it to support the fetus throughout that contraction. So during that contraction, we got a squeeze. So we've got some vasoconstriction, and the blood flow to the placenta is a little bit decreased. But there should be enough reserve that the fetus should be okay throughout that. But if that placenta is not functioning as well, and the reserve is diminished, as that uterine contraction starts to come to its peak, that fetus isn't getting what it needs from the placenta, and the heart rate will dip as a result. So that's really what we're looking at in this picture. We do monitor for those. So sometimes you might see some late decels, and we know that then those are related to the placenta. You see a couple other ones over there that's suspicious, so it wasn't consistent after each contraction, but we might continue to monitor. And then unsatisfactory, where it just wasn't monitored well. So again, non-stress test, we want it to be reactive. We want to see accelerations. Contraction stress test, we want it to be negative. We do not want decelerations. Some other diagnostic testing that you might be educating your patients on, it would include amniocentesis and chorionic villi sampling. So amniocentesis can be done at a couple different times of pregnancy. So this is where we withdraw a sample of amniotic fluid from the uterus and to test in the lab. So early on, after 14 weeks, this could be done for genetic testing purposes. And often would be done to follow up on an abnormal blood screen in screening for some genetic conditions. This is pretty standard to offer to women who are older or who have had an abnormal quadruple screen test. Amniocentesis, another reason it would be done would be to look for that LS ratio, to look at lung maturity. So this would be done later in the pregnancy if we're thinking we need to look at are the lungs mature enough to support delivery. This reason for amniocentesis is done less commonly than the genetic testing reason. So another one that could be done is chorionic villi sampling. So chorionic villi sampling can be done around 10 to 12 weeks, so a little bit sooner than the amniocentesis for genetic testing purposes. And while this can test for things like Down syndrome and other chromosome abnormalities, it does not detect neural tube defects, whereas the amniocentesis has the ability to detect those chromosome abnormalities as well as neural tube defects. So there is a little bit of a difference between them. One can be done at an earlier gestation, but doesn't test as much. So these are offered, and there can be some ethical considerations when you're talking about them because they're invasive. There's some risks with them, but there's some potential benefits in knowing what's going on with the fetus and being able to make some informed decisions. So there's a lot of conversations that might happen both between the nurse and the patient as well as the provider and the patient in what these tests do, what are the risks. Next, we're going to move into maternal nutrition. So this is an education piece often in pregnant women. So first thing I want to talk about is the needs during pregnancy. So there is an extra 300 calories per day needed during the second and third trimester. So this is to support the fetal growth. And you notice that it's not in the first trimester. The first trimester, they don't need that many extra calories because they're really not, the fetus is multiplying, but it's not growing substantially. It's not putting on fat and all those things. So these calories start a little bit later on. in contrast, you see there, and this is just to think about later, during lactation, when a woman is breastfeeding, she actually needs 500 extra calories per day. So your needs in pregnancy are even less than during breastfeeding. Kind of goes to show you, eating for two isn't totally true during pregnancy. Some things to consider when we're monitoring weight gain. So we do monitor weight at each prenatal visit, and we're looking for a pattern over time. Not just what did you gain from your last visit to this visit, but if it's a woman who's supposed to gain 25 to 35 pounds, and in that first trimester has already gained 20 pounds, then her pattern of weight gain is leading towards probably gaining more weight than is needed for the pregnancy. So that would be an educational opportunity. We see normally a little less weight gain early in the first trimester, and it picks up a little bit as the pregnancy progresses. Protein needs, as far as nutrition, increase from 45 grams to 70 grams daily. And this is for fetal development, blood volume expansion, and the growth of maternal tissues. So lots of needed protein. And again, like we talked about in a previous voiceover, is that fat is more readily absorbed during pregnancy. Other considerations that we want to talk about when we think about nutrition are some of those socioeconomic considerations. What are the access to food and financial abilities of the pregnant woman to buy the appropriate foods to support that pregnancy? And this is stuff that you guys are probably learning about in Pop Health with vulnerable populations, and you may hear the term food deserts and locations of grocery stores. So ensuring that these questions are asked early in pregnancy, and maybe getting some extra resources in the form of WIC or food stamps to help these women to ensure that they're able to support those needs. You also want to consider cultural things related to food and food safety in pregnancy and nutrition, because those are always going to come into play. Some psychosocial considerations that you want to think about is eating disorders. So pregnancy can aggravate eating disorders, even eating disorders that are in remission. So a patient that has been stable and in control, the thought that they're going to gain weight with pregnancy can sometimes cause some challenges with that. So talking through that and being aware of that history and working with the patient to gain a healthy amount of weight. Pica is eating non-food substances, and sometimes this is something women crave during pregnancy, things like ice chips or dirt or laundry starch. One of the concerns with pica is it puts her more at risk for anemia, because depending on the substance itself might contribute to anemia, but also just pica in general is leading to maybe not eating as much of the foods you need to be getting. So thinking of an anemia when they're eating things that are non-food substances would be important. And then vegetarianism. And the big thing with this, it's not that they can't do it or anything like that, absolutely not. But we go back to those protein needs. And those protein needs increase tremendously during pregnancy. So just having that conversation and making sure that the patient is aware of where you get protein within that vegan or vegetarian diet to ensure that they're meeting the demands of the pregnancy. Some other special considerations. So adolescents, and I don't have that on the slide, but they're challenged. They have to support, they're still growing. So they're supporting their own growth as well as the fetal growth. So that's a really big special consideration with nutrition. Folic acid, we've talked about this, very, very important. And that inadequate amount is associated with those neural tube defects. So this should be just happening all the time during preconception of any women in her childbearing years, and should continue through pregnancy. Artificial sweeteners are generally, they have not been deemed unsafe in pregnancy, but being sure to get enough foods and beverages to meet your daily needs. So ensuring that you're still getting the right amount of the good stuff is really kind of the key there. Energy drinks, current guidelines are to use with caution, monitoring daily caffeine intake and keeping it in moderation. So moderation's key with a lot of these things. Mercury and fish. Pregnant women should eat fish. Okay. The fish that should be avoided are fish that are higher on the food chain and tend to live longer, grow larger, such as swordfish, shark, tilefish, and king mackerel. Tuna is okay in moderation, as long the albacore tuna actually has a little bit more. So the cheaper tuna in the cans is generally considered okay in moderation during pregnancy. So a little different than what we've probably heard, but you do want to eat some because of the omega-3 fatty acids that you're getting from there. So it can be beneficial. Lactase deficiency, the enzyme is totally okay to take during pregnancy or the treated cow's milk. And then foodborne illnesses. So this is what we hear a lot about with talking about what you can and cannot eat during pregnancy. So a couple of things to think about. So we want to avoid raw or undercooked foods that might have a risk for salmonella, and also avoid foods that are at risk for listeriosis. So we want to heat lunch meats. Don't eat cold deli meats. Don't eat cold hot dogs. Heat them up, cook them. Make sure you're putting leftovers away within 2 hours. Avoiding soft or unpasteurized cheeses. So unpasteurized cheeses might have a risk for some of those bacteria because they haven't gone through that pasteurized process. Sometimes these are common in certain Mexican cheeses. So again, that might relate to some of those cultural considerations. Unpasteurized milk would be another thing, as well as some meat spreads, smoked seafood that is refrigerated. The canned smoked seafood or shelf-stable seafood is generally okay, but the smoked seafood that's refrigerated could be at risk for those foodborne illnesses. So ensuring that women are aware of that. The raw foods, so like sushi, they cannot eat sushi that's made from cooked foods, but you don't want to eat the raw version. So just making sure that you're handling all of that correctly. So another thing that's mentioned, and the book doesn't talk about this a whole lot, DHA is considered essential through all stages of life, and this is probably something you've heard about. And this slide just highlights what DHA is beneficial for. So in supporting maternal health, the normal gestation period, but then it promotes the fetal brain and eye development, which is really, really important. And it continues to do that in infants and children. Anymore, this is usually found in most prenatal vitamins, but again, it's just something to kind of highlight. It's also found in many children's vitamins and the formulas and stuff if a woman is formula feeding. So next, we're going to get into some of the other nursing care that might be going on with these pregnant women, and again, just digging into more of this detail. So some of the things you're going to educate on early, and we talked about what we're doing at visits, but how often do these women see the doctor? And so every 4 weeks until 28 weeks gestation, and then every 2 weeks until 36 weeks, and then weekly until birth. And this is true for low-risk women. If there's any complications or anything that bumps a woman into a high-risk category, this would change, and they would need to be seen more often. In addition to this, what do they need to know? Because 4 weeks in between visits is a long time. So what do they need to know to be aware of when to call the physician for problems is an important piece of education. This talks about several of those considerations that would be a concern, and would also, it also identifies what might cause them. So a gush of fluid from the vagina. So that could be the rupture of amniotic fluid. And it would be considered a danger sign if it's preterm. But either way, it's something that would need evaluated. So that would mean, hey, you need to get a hold of your provider or come to the hospital. Vaginal bleeding, definitely a danger sign because it can indicate some problems with the placenta, or if it's early pregnancy, even some risk of miscarriage. So that's a danger sign, and they should be contacting their provider or coming in for any of these. Abdominal pain that's severe could happen for a variety of reasons, but would need to be checked up on. That change in fetal activity, like we discussed. Persistent vomiting to the point that they're not keeping anything down. They're at risk for dehydration, which can complicate the pregnancy, and many other things, so we want to make sure that that's getting taken care of. Any severe headaches that might be related to high blood pressure would need evaluated. Elevated temperature from infection. Dysuria might also indicate a urinary tract infection, which they're at risk for because of that decreased capacity in emptying. Blurred vision, again, that could be related to high blood pressure. And then a puffy hands or face from edema could also be related to that. Some other things that you'd want to Also add to this list would be seizures. Obviously, seizures would relate to progression of preeclampsia. Blurred vision. Blurred vision can occur with those preeclampsia as well. I guess that is on here twice. So the epigastric pain also could be indicative of preeclampsia. And then oliguria, so low production of urine would be a concerning sign. All right, and this is all for today. The next PowerPoint will be alterations in pregnancy, and we'll move into some more of what those conditions are. Thank you for listening.